Nothing contained in this podcast should be considered a substitute for professional medical advice. This content does not represent our respective employers and is purely the opinion of the podcast hosts. We are not your personal medical providers. Sorry, friends. So, if you have concerns or seeking a diagnosis or treatment, please seek individual advice from a healthcare provider in your area. We are not liable for any risks associated with acting upon the information contained in this podcast. This is intended for educational and entertainment purposes only, so enjoy the ride.
Please drink responsibly and in moderation. Before drinking, please be sure to be of the legal drinking age for your country. We do not encourage the misuse of alcohol.
Welcome to Medical Media Mixer, the perfect cocktail. I'm Nicole Peniston, psychologist.
And I'm Tara Prisco, physician assistant. So we have a new feature on the pod. We have our first guest, Kateland Kelly. Welcome.
Welcome.
Thank you for having me.
So interestingly enough, we'll get a lot into Kateland's story, but the way I came across this was I think on some random PA board, because I'm also a PA, and Kateland is as well. I mentioned something about my podcast and she chimed in and said, well, I have a story for you.
Yes.
And so I promptly looked her up, downloaded her book, read it, and was like, all right, we got to do this.
Yeah.
So let me give you a little background on her and then we'll chit chat. So Kateland, has a very unique story, and I'm not going to spoil her book because I really suggest everybody reads it. But she has a big journey. She was born with a cardiac deformity as a child, and throughout her lifetime, quite a few roadblocks with misdiagnosis. And eventually she kind of went into the medical field, probably somewhat inspired by this, I would say, by your own medical struggles. And she ended up in sort of this medical nightmare that nobody imagines they would be in, where she herself was the patient and was struggling to find a diagnosis and was hitting the lows of lows, hitting that bottom point, trying to find out what was wrong with her. So her book touches on her personal journey, but also really talks about some really beautiful patient interactions and stories, and also touches on a little bit of how medicine's broken and about how violence in medicine, which we actually just covered on our last episode, and just the way things happen for patients on their end. So it was a fun journey to read, highs, lows, but to me, it read like a fictional book in that I just wanted to keep going.
Thank you.
So anything else about your background you wanted to touch on?
So my primary background is primary care internal medicine, though I have done stints in oncology, specifically bone marrow transplant and emergency medicine. And my first love was always writing. So this book is kind of my love letter to the world and all the patients out there still looking for their diagnoses.
Right. So it's always interesting to me because we always think about, I guess, the medicine brain and the creative brain being separate, but you did a really nice job at melding those two things. And Nicole also loves to write.
I do. Yeah. And I think it's so inspiring that you could find the courage to kind of share this very personal story with people and help other people learn from it. We've talked many episodes ago about how that medical gaslighting that you're going to talk about happens so often to women, and how women in medicine, we need to be empowering each other and empowering our female patients to stand up for themselves. So hopefully we'll talk a little bit about that later too.
Yeah.
So the way when Kateland answered me online was saying, I found my diagnosis through an episode of Grey's Anatomy, which is sort of amazing. Like you said, we tell patients not to Google, but hey, sometimes...
Exactly.
Sometimes that's where the answer comes from.
I was just watching the wrong TV show.
Or the right TV show.
Right. Exactly. So somebody pointed that out to her, and then that's how she found it. So I'm going to go a little bit into that specific episode. So this is the episode called Everyday Angel by Grey's Anatomy. And so I'm going to introduce our cocktail as well. I see my as we talked before, my new friend ChatGPT helped me make this cocktail, and I actually think that he did a pretty good job.
So it's perfect.
So the cocktail is called the Arcuate Angel. And so Arcuate really means curved. And so the name of the episode being Everyday Angel, we took kind of those elements together. It's 2 ounces of Empress 1908 gin, which is like that indigo purple color, which will turn lighter when the citrus hits it. 3/4 ounce of elderflower liqueur, Saint Germain or something similar. 1/2 ounce of fresh lemon juice, 1/4 ounce of lavender syrup, and 2 dashes of Peychaud's bitters. Took all those, put them in a shaker with some ice, and I served mine in that coupe type glass, martini glass. Nicole, I think, has hers in a highball glass, whatever works.
Mine's not as pretty. I didn't have the purple gin.
Oh, nice.
So the episode, really, the character that goes through this whole diagnostic process is not the center of this episode, but that's what I was tuning into and looking at it to follow their story. So the patient's Nina Sullivan arrives at Seattle Grace Hospital after she's seen multiple providers for chronic abdominal pain without any relief. She comes in looking exhausted. She has a big binder of medical records. She's frustrated. And she states, I've been diagnosed with gastroesophageal reflux disease, anorexia, anxiety, all these different things. And she says, I want Dr. Meredith Gray because that's the only person who can save me. But Meredith's not around that day. She's not really in this episode at all. So
she's at home baking cookies that day.
She
literally.
Is. So Joe and Bailey initially sort of already dismissed the patient with skepticism. And then Bailey says, well, I taught Meredith everything she knows, so we'll figure this out. What's interesting is they do something which I've seen on TV and I've seen maybe in like a resident's morning meeting, but taking a big board and literally going through the differential, because that doesn't happen in every day. I mean, you're in internal medicine, I'm in internal medicine, primary care. We can't sit there for hours and do that. Yeah. But it was interesting because even though they dismissed her, they did give her the time of day and spent, it looks like, the whole day trying to figure out her diagnosis. But basically they went through the list, every test that she had done, and they were like, well, we don't know, essentially. And she's like, well, I've been fasting all day for all of these tests. I'm going to eat my sandwich that I brought with me. And, she also sort of makes a bit of a suicidal ideation or threat saying that, if you don't figure this out, I'm going to kill myself, which in TV sounds dramatic, but that is so real. And Nicole, being a psychologist, understands this too. Physical pain and distress and medical troubles are often a driver of something like that. But then as the patient's eating the sandwich, they see her double over in excruciating pain and the light bulb goes off, kind of like the Dr. House moment.
Exactly.
Well, and I was curious, was that realistic of how quickly it happened? Because it was like one bite. And then I was like, I think she would need a little bit of time for the food to start to digest.
So what I will say is that postprandial pain is one of the cornerstones of the diagnosis. So it would be very unlikely for the patient to just bite into the sandwich at that point and then, oh, there's your answer. The patient will come to you saying, I can't eat because the pain is so severe. So no, that part was not realistic and is slightly criticized in the MALS community from a patient perspective. But it is representative of how severe the pain is. That part is very much true.
Yeah. So, I mean, I think that, with anything, at least starting the conversation on a rare disease and portraying it in a media piece like that is great. They're never perfect with these things. And that's part of what we do in our whole podcast, that some of these things aren't portrayed perfectly, but it was nice to actually see something so rare.
Absolutely. Yeah.
So, if now, Kateland, you could share a little bit about your personal diagnosis with MALS and how that came over time.
Yeah. So what's interesting about me is I think I might have the most complete medical history of a MALS patient, starting with my birth in 1986. My mother kept meticulous records when I was born. I was born with a ventricular septal defect, and I couldn't eat at birth. So I was diagnosed with failure to thrive, but I had sustained cardiac arrest twice in the first 6 months of life. And every time I go to the hospital, the doctors would say, well, maybe it's colic, maybe it's cerebral palsy at one point. They even went so far as to test me and my parents for HIV because it was 1986 and they didn't know what they were dealing with.
Right.
So my mom would take me for the first few years of my life, every 6 months or so, to the emergency room for basically dehydration, acute kidney injury, that sort of thing. And then miraculously, I kind of grew out of it for many, many years. I always had kind of weird abdominal pains, pretty easy for a pediatrician to dismiss, viral gastroenteritis here, growing pains, that sort of thing. When I became a teenager, I got sick in a different way. I was having what I would describe liver lightning episodes, which were right upper quadrant sharp shooting pains. Nobody really could put anything on it. Again, young teenage girl, 14, 15 is kind of when it started. Maybe she has some disordered eating, maybe there's an IBS component, an anxiety component. Who knows? But it got to the point where on and off I would end up being hospitalized for IV fluids. And it felt so strange to me as a young woman dealing with that. So we went to multiple doctors. One pediatrician decided to run a CMP and my liver enzymes were in the So that put me down a diagnostic pathway that was ultimately diagnosed as autoimmune hepatitis. At that point, I was about 16 years old and put on a pretty heavy-duty course of immunosuppressant therapy. But at the time, I had no idea what the little yellow pills were. As I write in my book, there was no WebMD. There was no internet, medical, anything for me to consult. And as a young person, my parents did what they thought were best, and they didn't really tell me what the little neon yellow pills were for. They just said it was for your pain. I then went through a lot of complications with those medications. And I remember being about 16 or 17 years old. And at that point, I was being transferred from Hartford Children's Hospital, getting ready to go to an adult doctor, a big doctor, right? They're not going to treat you after age 18 or so. And when I did make that transition, I asked the adult doctor, how many pediatric or young adult cases of autoimmune hepatitis have you treated? And he got really pissed off when I asked that question, to the point where he said, you're not the doctor, I'm the doctor, you do what I tell you to do. And that kind of put the bug in me. And I'm like, I think I'm going to get my white coat. I think I'm going to figure this out. I want to know more. I'm the first person in my family to go to college. You know, going full MD just wasn't realistic for me. And I was pretty sick. You know, my high school guidance counselor told me, go to college. Let's see what happens with your medication regimen. Let's see how you do. You know, take a gap year. So I wrote a really killer essay about what it meant to live with pain. And I got into a pre-PA program. I flunked out of the pre-PA program. They were playing around with my medication my sophomore into junior year, and I couldn't maintain the GPA that I needed. It was a very competitive program, as they tend to be. And so I finished up my undergraduate degree with biochemistry, but I was 1 credit shy or so of a minor in creative writing and journalism. Because again, the writing was
always there.
It was always there. It was my passion. It was what kept me connected. Flash forward to getting accepted into a PA program in Virginia. I was waitlisted. I took the spot. I moved down to Virginia almost sight unseen 2 weeks before the program started, and I really loved my program, and I did really well down there. And I stopped worrying about myself for a while. When you're in PA school, you're spending a lot of time learning how to take care of other people.
Yeah.
You sacrifice yourself. And anyone that goes through any kind of medical training knows what it's like to sacrifice yourself. You know, your 20s are not yours.
Yes, it's true.
I lived with pain, and I just thought, you know, this is my normal. I hit about 8 years or so on the immunosuppressants, and my liver enzymes normalized, and they did 3 liver biopsies and said, oh, you know, actually your autoimmune hepatitis is better now, which that doesn't really happen.
Right.
So they took me off the immunosuppressants, they took me off the steroids, and I was okay for a while. And then I started practicing medicine, and about 10 years into it, I got into a car accident, which kicks off my storyline in the book, The Secular Prayers of Medicine.
Right. So, you know, your journey up to that point, obviously just having a complex, you know, medical history to start with, you know, this is something that you didn't learn about MALS in school, right? I don't remember learning about MALS in school.
Not in the slightest. Not at all.
Right?
Nope.
So it's not even something on our radar. It's really not. Now it will be.
Yes,
now I am a zebra chaser, so I will be having it in the back of my mind all the time
absolutely.
now.
Well, no, it's
and I'm also always mindful of it because so many of those people with those rare medical diseases get referred to me for psychology because they think it's all in their head. So I'm always trying to keep track of what is out there and what could this possibly be if it's not mental health or what started off as medical and now is mental health because you're so overwhelmed. So it's important for everybody to know about it.
Yep, it's that chicken versus egg.
So, you know, I'll talk a little bit about what MALS is, and we can kind of get to how you got your actual diagnosis. But the other name for it, so it's median arcuate ligament syndrome, also called Dunbar syndrome. And apparently it's always named after somebody, right? So it was actually discovered by somebody else slightly before, Pekka Tapani Herjola in 1963, and then further characterized by David Dunbar and Samuel Marable in 1965. So the definition of this is essentially, you know, your anatomy is just different. There's nothing you did to cause this. There's nothing you can do to prevent this. Your anatomy, the ligaments sort of, I guess, under your diaphragm and towards your spine, the way they support your blood vessels is slightly abnormal. And so it sort of kinks that celiac artery, which feeds our GI tract. And so some of the symptoms you mentioned earlier, right, that postprandial. So for our listeners who are non-medical, postprandial means after eating. That pain because, well, blood supply comes to your stomach to help digest, and then it can't. What was interesting was the first study, I guess, that you needed to have done was a specific type of a Doppler, right? An arterial Doppler of the celiac.
Yeah, exactly.
Is that something, I've never even ordered a test remotely like that. Is that something that was even hard to have the hospital do, or the imaging center?
So when I had a car accident. So when we're thinking about MALS, you're going to either have a congenital presentation or you're going to have a traumatic presentation. You can develop MALS if you have blunt abdominal trauma. In my case, I just had, both. So in my case, I was driving to work the weekend of Thanksgiving to my outpatient urgent care, and my steering column failed, and I ended up going into a ditch at about 65 to 70 miles an hour. I don't really remember the car accident, but I do remember somebody knocking on the window saying, "Are you alive? Are you okay?" Airbags deployed. It was got to get crunched out sort of thing. I was taken immediately to the closest emergency room. I had a CT scan of the head, neck, and abdomen, and it was read as clean. It was read as, "You're okay. You're good." I was diagnosed with a concussion, of course, and you don't walk away completely unscathed. But from that moment onward, the heartburn that I'd always dealt with, the abdominal pain had become not intermittent, but daily and persistent. So that heartburn then kind of morphed into vomiting reflux. And I would wake up at 2, 3 in the morning vomiting. And it wasn't things like trigger foods like you'd expect, like citrus, tomatoes, it was just crackers, noodles when I did. So
anything.
Anything. So I started with my primary care provider. And of course, they're like, 6 months of monitoring, do a food journal, do an elimination diet, do Tums, do Pepsid, do, omeprazole. We went through that kind of gastro reflux, algorithm. Got referred to GI. GI has said, all right, let's go ahead, do an endoscope, a colonoscopy. Let's check you top to bottom sort of deal. And I remember the gastroenterologist said to me, he goes, you didn't prep properly. You didn't fast properly. And I had explained to him, I said, the macaroni and cheese that you saw in my stomach during the endoscopy, that was from 18 hours ago. That was, I fasted. So that led to me getting a referral for a gastric emptying study, which is a particular type of test in which you eat radioactive food, in my case, eggs, and then they take a series of x-rays, watch that go through the transit. I was diagnosed with gastroparesis, so paralysis of the stomach or slowed gastrointestinal tract. Now, for me, gastroparesis, yes, it's a diagnosis, but it's a symptom. And so for me, I kept pushing. I said, okay, well, I'm not diabetic. We've ruled out MS. Idiopathic gastroparesis in a young 30-something-year-old, what is this?
Right.
So I went from specialist to specialist for second opinions. I went to a general surgeon because they found a hiatal hernia. But the minute that the general surgeon found out I was now vomiting 10, 15, 20 times a day, he put his hands up and he said, I'm not operating on you. We can't do a hiatal hernia repair if you're vomiting. Cue the psych referral, right? Like, oh, you're vomiting a lot. Oh, well, you're a little overweight. You're a little fat. Maybe this is some bulimia going on. Okay.
Right.
And I mean, I played along. I did all the referrals. I was a good patient until I wasn't. Nothing was changing. We went through the gamut of different medications. We imported domperidone, which is an agent to kind of increase that gastric motility from Canada.
Yep. Often used in women who have nausea during pregnancy.
Yes. And nothing worked. Absolutely nothing worked. So I started at about 222 pounds. In less than a year, I hit about 130 pounds. And the last time I met with my gastroenterologist, he kept complimenting me, saying, it's good you're losing weight. You're fat. It's better. Your symptoms will get better if you lose weight. We don't know why you're losing weight, but you're still fat.
I've heard that exact thing.
Oh, I know. We all have. And that's a big theme in my book, right? Like, sure, lose weight. Okay, I acknowledge being a healthy weight is healthy, but it's part of it. It's not the whole thing. Go do yoga.
Exactly.
I do yoga every day, like journal. I've got scores of journals. So, hitting those barriers and then being told, well, all your tests are normal. They weren't entirely wrong. All the tests were normal. It was just we weren't ordering the right tests at the right time. So long story short, I decided to move from Vermont, is where I was living, back down to Connecticut. And it was the pandemic years. So that, right, everything got kind of weird during the pandemic years. Everybody was shutting down. Specialists weren't seeing people. They weren't doing elective surgeries. Like, very, very difficult to get any access to care. All throughout this time, I'm maintaining my alter ego online, the Right Assistant. So I started the Right Assistant 20 years ago at this point. And it was it was just kind of a fun pun, right? I knew I wanted to be a physician assistant. I knew I wanted to be a writer. The Right Assistant. And I did copywriting for years, so just small side gigs. I became Etsy's top copywriter for a while, and I was the editor for the Handmade Seller magazine. So I had a pretty decent online presence for my writing alter ego. And I'm going through all these tests. I'm becoming more depressed. I'm moving states to seek medical care. And I get a message in my inbox from a random person saying, watch this episode of Grey's Anatomy. Why?
It's amazing.
Who are you? And when we have patients say that, right? Oh, have you seen this episode, or have you watched this TV show? We all kind of hold our breath, maybe roll our eyes a little bit. And I was desperate. And I was sitting on the couch, so I'm like, let's watch the episode. Literally, as you said, she's not even the main case in the episode.
Right.
But by the end of it, I was bawling my eyes out. And I said to my husband, I'm like, this is it. This is my diagnosis. And he just kind of looked at me like I was crazy too. And he's like, okay, all right, you're latching on to something.
Sure.
Which is a normal response.
Right.
And and I just remember saying, no, like, no pun intended, in my gut, this matches. Every clinical presentation from childhood onward, this matches. And to order the mesenteric ultrasound or the Doppler ultrasound, you can also do MR angiogram.
Okay.
I had to beg the gastroenterologist to order it for me. So this is when I relocated down to Connecticut, and I felt like I was presenting a case to my attending, as I wrote in my book. Like, these are the symptoms. This is the test. This is, and I remember her saying to me, even if we order this test, even if we confirm it, there's no treatment and you're too young, we don't recommend the test. I'm like, well, that doesn't make sense to me, right? Like,
no,
none of that makes sense. I'm like, just order the test. And
right.
I truly, truly believe the fact that I had a white coat, the fact that I was working at the local health department at that time for COVID response. I really think that doctor gave me a professional courtesy and said, all right, well, I'll order this test that I'm not familiar with.
Right.
Don't really know where to send you if it's positive. And I said, it's okay. I did my research. And
right. I mean, but that is true. We are taught, right? Don't order a test you don't know what to do with. So I understand that initial trepidation because you're supposed to always, right. But, giving the patient the benefit of the doubt, it's non-invasive. It doesn't cost a lot for Doppler ultrasound,
No.
At that point, why not?
And it's unfortunate that, like, luckily you had that white coat background that you could present that, where someone without that knowledge might not be taken seriously, even if they had the same information that you did and were requesting the same thing.
Yes. And that's what I write about in the book a lot, is my white coat privilege saved my life because I knew which words to use. If you go into a doctor's office as a patient and you're crying and you're picking your fingernails, or, you're a little bit looking around because you're anxious and your blood pressure's up, you're already going to get pegged as a patient that's, either hypochondria or drug seeking or, just one of the many components of anxiety. And it's so much more than that.
Absolutely. So once you finally, got this Doppler and it confirmed the diagnosis, then the next step was then to find somebody to treat it.
Yeah, a vascular surgeon.
So,
yep.
Right. So where did you even find somebody who knew anything about this?
Yeah. So my everyday angel that messaged me, she was actually the individual that inspired the Grey's Anatomy episode. It was her and her husband that had reached out to me. Yeah. And so it was very interesting because she traveled from out of state, from many, many states away. And she traveled to Connecticut for her surgeon.
Right in your backyard.
Right. Literally right in my backyard. So my surgeon was a surgeon that had a office 5 minutes from my practice. So he was a network.
Wow. That's amazing.
That's amazing. Being
Often,
a network.
Yeah. Because, we're in New Jersey. And so I often am like, okay, well, here's what we have here. We're lucky. We are not in a medical desert, by any means.
Right.
But when I have a patient like that who's rare, I'm like, all right, it's New York or Philly. We need the people who write the papers, not the people who read the papers. That's what I tell my patients who have these complex things, because it's not always accessible.
No, it's not. And many MALS patients will travel. What I love about his particular practice is he's got a map of the world and a map of the United States. And after you have surgery with him, you're invited to put a pin on the map. And I'm number
Oh, I love that.
600, I think 51 or 41. I usually flip it in my head, but I'm in the first 1,000.
Yeah.
Wow.
And they just celebrated this past year breaking 1,000 patients for this particular procedure. So Connecticut is definitely becoming known as a destination for this.
So explain a little bit about the procedure. So I understand part of the process to know if it was going to work was you had to do a block of that nerve, right? To see if that was the cause.
Yes.
So I remember that being, I read your book a couple weeks ago, but I remember that in itself being, tough to do the test, but then in the end being.
It was a wild ride. Like, it was a wild ride. So it was still high COVID. So my husband was not allowed to come into any of the hospitals with me. I was doing this solo, which is terrifying without a pandemic in the background. So every day I was terrified I was going to catch something from one of my patients that would then prevent me from progressing with this workup.
Right.
So my surgeon explained that you had to do a celiac plexus block as part of his requirements to go forward with surgery. And I remember getting to the hospital, and I felt very disassociated the whole time. I'm like, this isn't real. I'm doing this all based on a TV show. This can't be life. And up until that point, so many of my experiences with specialists were pretty sour, very dismissive, very, there's a crazy abdominal patient. The team that took care of me doing the celiac plexus block, they were angels. They were kind, they were supportive. They were very used to seeing people at the end of their ropes. And so I get there and they explain the procedure to me, and they say, you're going to be awake for it. You're going to be laying flat, face in a little cradle, and they're going to insert a needle on either side of the spine, targeting the celiac plexus blocks from a posterior approach. And they used a combination of a steroid and lidocaine for me. And it hurt like hell. I have no problem saying that out loud. Oh my God.
Yeah.
It was one of the worst pains I'd ever felt. And I was at that point living with excruciating pain. When we look at some of the clinical literature and the studies that we have of MALS, patient reports are akin to end-stage pancreatic cancer when it comes to the level of pain that we're dealing with. It often is not responsive to our standard medications orally. It's often not responsive to narcotics. In fact, narcotics often will make it worse with rebound, decreased gastric mobility. So I'm sitting there thinking, I made a mistake. The pain is worse. It did not work. So I'm texting my husband after I get out, and it's only a 10, 15-minute procedure, honestly. And I'm texting him saying it didn't work. I made a mistake. We now have this giant bill for this test that wasn't really going to do anything for us. And one of the nurses hands me a menu and says, okay, go ahead and order something. And I hadn't eaten food in about 3 years outside of ice cream, Boost, Ensure, crackers. I could eat pierogies. I ate a lot of pierogies for 3 years.
I just had pierogies 2 days ago.
I love them.
That's not bad.
And so she said, order. And I'm like, all right. And so I craved salad and water. I couldn't drink water. So I got a Caesar salad, chicken Caesar salad, a couple of grapes, some cantaloupe, and I ate it. And I just cried while I ate my $10,000 Caesar salad. And it was amazing. So the second part of the test is you get the block, you eat the food, and then you had to travel across the state to go to the surgeon's office. And then he would do a physical exam on you. And part of the cornerstone of physical diagnosis is epigastric pain after eating. So, right, we push on the epigastric region. If the patient kind of pushes you away or has an episode of vomiting, then you know, right? And he pushed on my belly, and I'm like, do it again. It doesn't hurt. Do it again. And he was very matter of fact. He was, he's the perfect surgeon, just straight to the point, and said, your anatomy matches, your testing is positive, you'd be a great candidate. Try to gain some weight, and if you want to be put on the wait list, we'll put you on the wait list. And at that point, it was about a 6-month wait list for him. And I said, absolutely. That'll be perfect. I had just started a relatively new job in outpatient urgent care, so my benefits were going to kick in, right? Like I'd be able to take my time off. And a couple weeks go by, and I'm training a new nurse practitioner on shift, and I get an email because I didn't answer the phone call, and they gave me a date for 6 weeks later. So I had to
Wow.
put in a leave of absence for my job very unexpectedly, and away I went for surgery.
Wow. Amazing. And so the actual surgery itself, the technique that they use, or what are they actually cutting away, or what are they doing during that surgery?
Yeah, so there's a couple of different approaches. I was an open abdominal repair, so I've got a pretty significant scar from just underneath kind of my xiphoid to my belly button. There is, I'll show you because it was published 1 month before my book dropped. It's only one of 3 medical textbooks on MALS. So for any clinicians that are really interested in this, Dr. Danny Shoheed and his team are phenomenal. They went ahead and they published. It includes everything, including the pictures of the surgery.
Can you actually text me that name so I'll add it to our show notes?
So it was wild for me to kind of see what they did. And I'm sure you can't really get a good view of it, but they open me up all the way. They dissect all the way down to the celiac artery and the ligament. In my case, the ligament was cut to free the artery. And then the surrounding nerves, which were very necrotic and very inflamed, they were cut down and pared down as well. So there's some nerve lysis as well. My surgeon advised me that it's fascinating. It's fascinating. It didn't exist 10, 15, 20 years ago, So I can't be mad. I can't be upset about any of the doctors missing the diagnosis because we just didn't know what we didn't know. And that's part of the equation that patients forget. And I do try to represent both sides of the exam table, is that we try to practice hopefully at the top of our scope, but sometimes we need to determine next steps and we need to be pioneers. And this is what these vascular surgeons are currently doing. They're absolutely taking risks and taking these very complicated, often very critically ill patients on, but the rewards in some cases are life-saving. So cut the ligament, cleaned up the nerves, sewed me back up, and that should be that. We were told about maybe a 2 to 4, maybe 5-day hospitalization. Make sure you're walking, make sure you're passing gas and pooping and all that good stuff.
Yep.
And I stayed in for 22 days. So
goodness.
I didn't do it simple. No, I had a lot of complications.
It's always how it happens.
Yeah. So it was very eye-opening to see exactly what happens to patients in that situation.
Yeah, being on the other side of it, you have the patients complaining to you sometimes and you can't be there every second as a provider. And so you're like, well, the nurse and, the dietitian and this and that and coordinating, it's tough because being a patient and you're kind of helpless.
Yeah. Well, and I'm glad that you could tell us that because I feel like the episode really just went to diagnosis and then you never heard about that patient again. And I was like, wait, is she doing okay now? Can she eat? Did it work? And it was just kind of like,
procedure.
Yeah, I was curious about that too. I was like, if it's that easy, what?
So not that easy. The fact that she had a surgeon the next day or imaging the next day, that's impossible.
Right.
Yeah.
Right. I mean, you're literally going as far back through the abdominal cavity as you can. Everything's moved. I mean, this is not just like open it up. I mean, a gallbladder is nothing. This is like we're going deep in there.
And that was something that I found really interesting. So I knew going into the hospital that one, they were understaffed, high COVID, a lot of float providers, a lot of float, nursing staff. And so I'm like, I'm going to come in with treats. I had a big bowl of chocolate right at the entrance. I had my husband set it up. And, when I introduced myself to everybody, I'm like, I'm one of you. I have food. I have treats. It didn't matter. Didn't matter. No, no sympathy, no bonus points. They looked at me like I was a very complicated patient that was pain-seeking and not doing what I needed to. They were looking at me like a gallbladder patient saying, why are you here for 10 days? Why aren't you getting better?
Right.
Walk. So, but it wasn't that simple.
But in the end, how do you feel now? How do you feel?
Yeah. So it took about a year. The surgeon quoted me it'd take about a year before you would get back to a baseline or there's always going to be pain. There is no cure for MALS. You spend a lifetime with this much compression and you're going to have reflexive pain. It's just a different kind of pain. I can eat food. And that was really what I needed. I shared on my social channels that in anticipation of tonight's podcast, I rewatched the episode. And it was the first time
I did see that, yes.
It was the first time I watched it since my surgery. And I didn't realize how hard it would hit me because I had my plate of food and I had my book and I'm looking at it and I'm saying, yeah, no, it worked. It was worth it. So for all the patients that question, you know, should I go through with MALS surgery? MALS in and of itself won't kill you. It's the surrounding complications, the dehydration, the hypokalemia, the heart arrhythmias that then develop because of that. So only you know how bad that pain is. If you can manage it with physical therapy, medical marijuana is a cornerstone of treatment for this particular diagnosis. If you can do biofeedback and get a handle on your pain and live a functional life, you don't necessarily need to pursue surgery. But for those cases where the patients keep dropping the weight and keep bouncing back and forth through the ERs for IV rehydration, those are the ones where the surgery really, really is life-saving.
Absolutely. So what's interesting is, you know, you can find statistics, but there's not a lot out there. There's a few papers, a few diagrams. You know, the statistics I found that anatomically, anywhere between 10 and 24% of people can have this anatomy, but most don't have symptoms.
Right. Yeah.
Which I found interesting. Yeah. And then have you learned that there's a connection with Ehlers-Danlos? Because I did read that in one source.
Oh, yes.
Okay. I am the EDS whisperer. I diagnose it left and right in my primary care practice.
Yes. Yes. Yeah. EDS is one of those things where, you know, I'm glad to hear that because not enough people think about that. And there are so many downstream complications of having a connective tissue disorder. Vascular compressions are just one of the many manifestations.
Absolutely. I mean, we actually did an episode on this. So I don't know if you've heard about the Empyrean books, what's the first book called? No, I'm not going to think of it. The Dragon books. Well, anyway, my brain is like the Dragon book, Onyx Storm and all those books. But anyway.
Yes. Yeah.
Yeah. So that main character actually has EDS. Well, they don't say it because in her world it doesn't have a name, but the author actually has it as well. So we did an episode on that already. So yeah, that's a fun one.
I'll have to check that one out.
Yeah, you know, but again, these things that present often in women, so EDS is one, you know, things like MALS, we've touched on it throughout, you know, our conversation, but we do see this, what we call medical gaslighting, where these women get told it's all in their head. I think, at least in my mind, we're changing that because as good or bad as the internet is, I think information and groups where people can talk to each other and understand each other's shared experience has finally opened these doors. But it's something historically, and all of us as women have probably experienced even the tiniest bit throughout our lifetime. I would say most have, right?
Yeah, I would too.
You know, so any chronic or unexplained symptoms are often called psychosomatic, mental health, famously fibromyalgia, IBS, anxiety, eating disorders. All of these things are sort of lumped together into a very particular patient type. And so it's interesting, you know, like I said, I'm a zebra chaser. I'm always looking for those because I almost medical gaslighted myself.
Yeah. Yeah. Okay.
I went through a period of unknown symptoms and really came to a point where all the tests were negative. And I was like, well, it must be, you know, I don't know, chronic pain because it's in my head. But eventually I came out with a Crohn's diagnosis and an undifferentiated spondyloarthropathy diagnosis. And I respond amazingly to immunosuppressants. So if it was in my head, immunosuppressants wouldn't fix it. But with all of my knowledge, I couldn't see my own self in front of me because it was like, well, everything's negative. Like it must be that I'm crazy.
Absolutely.
But I'm hoping that we're changing that narrative, right? I hope that we are. And Nicole, as you've mentioned, these patients end up in the psychology or psychiatry offices because of this, right? Yeah. And then sometimes you're having to say, well, no, you need to go back in the other direction.
Yeah. And I think along with both of the stories that you just told, and I'm currently going through my own kind of mystery diagnoses or trying to, you know, identify what's going on, it becomes very frustrating. And so by the time I see people, by the time they end up in my office, a lot of them are very angry or very upset and very dismissive. And I want to support that feeling. I want to tell them, yes, I want to validate you. You are justified in feeling this way. If it's not a psychological root, there's definitely psychological after effects of this. So let me help you at least manage that. Let me help you manage the anxiety that you have about your health. Let me help you manage the anger that you have towards the healthcare system. Let me help you manage the depression because you can't function the way that you want to. And so hopefully that's giving those patients that feeling that psychology supports them and it's not all in their head, but what is in their head we can help with.
Right. That absolutely makes sense. Help you to manage what you're going through, but still validate what you're going through.
Yeah.
Absolutely.
In primary care, I've made it my mission essentially to sit and listen. And because I'm a middle-aged female, I attract a lot of middle-aged female patients who aren't heard, right? So even today, I sat in the office with somebody who's like same age as me and like upset. And, I have these GI complaints. I have these joint complaints. I have this. All the tests are negative. I'm seeing derm. I'm seeing this one. I'm seeing that one. And yeah, I might not have the answers, but I'm going to keep supporting you to help find the answers.
Exactly.
Refer you to maybe a rheumatologist who I believe takes a little extra look at patients, somebody who does take a step back, finding other people out there. Because in primary care, we can do a lot. And I will order the workup to start. But then we can become limited to a certain point. I'm not going to start you on a biologic like that's out of my, my realm. But we start to get to know what other providers out there are willing to listen and start to try and refer to them if we can, ideally.
Yeah.
And I think we all understand like the power of just leaving a doctor's office and feeling like, okay, even if they can't help, they heard me, they believe me, because that in itself is powerful.
Absolutely.
Right. We've talked a little bit about this too with our body language when we're speaking to patients, not being in our computer, not turning away from them, looking at them, making eye contact, listening, and not always talking. So
Absolutely.
I just think there's sort of a little revolution happening out here with us middle-aged women.
I think so. I think
we're speaking up.
Yeah.
And I think we're finally in a place, and like I said, the internet, as bad as it can be in some places, it is definitely found a place for these people who need to be heard. So
Absolutely.
I think our sort of summary of this is find your people, find your diagnosis, do your own research has become a catchphrase. I'm going to say, gather your information and bring it to a provider who can maybe sort through it.
Yeah.
Yep.
And to quote some movie that I can't think of right now, we're mad as hell and we're not going to take it anymore.
What movie is that?
I can pick, it's Sally Field saying it. I know that.
Okay.
And it's from the 70s. But other than
Nicole,
that, I can't
you're supposed to be the person who knows all the cultural references that I can't come up
the
with.
obscure ones I can quote, but I can't tell you where. It's a thing, though.
I wrote, and there's a line in my book I said, I was either going to go mad or get mad. I decided to do both because it really did drive me crazy. And that there's the one scene where she's crying in the episode where she's saying, I'm not crazy. All you doctors telling me I'm crazy. If you don't diagnose me, I'm going to kill myself and prove you right. And I can't describe how accurate that sentence is. Because if you do read my book, you will read, I am a suicide attempt survivor.
Yes.
I was very intentional. I wanted my colleagues to find me. I wanted the people that weren't listening to see me as a cautionary tale. Just like that fictional character, you get to a point where you literally get mad and then you go mad. So by listening to our patients, by validating their experiences, and also just by sitting in the room with them, sitting with that pain and saying, I don't have the answers, but I empathize with you. That's powerful. So that's what I hope people get out of my story is that we are all a diagnosis away from a horror story. We never expect ourselves to go through this pathway, but we're human. We all get diagnosed eventually.
Yeah, absolutely. I really thank you for being so honest and sharing your story. I mean, your book goes into a lot of detail. Again, Secular Prayers of Medicine, which the title, the way you pull it all together. Like I said, I'm not a nonfiction reader by sorts, but it drew me in. So I really suggest everybody to also just look at the way medicine is and really to get that perspective. I really, there's holding up a
wonderful.
copy.
Yes.
Available at quite a few local bookshops. I know you've been going on some tours. Is that across the country? Is that more local in the local bookstores?
New England. So we kicked off the tour actually in June at Yale. So I've had the privilege of being invited now 2 years in a row to kind of kick off their psych unit. And it's because I have a presentation that I've been presenting at different medical conferences, including the Connecticut Academy and the Utah Academy, called When the Clinician is Suicidal. And it's an interactive case series where we look at, the traumas that we deal with as clinicians, like your episode with medical violence. I talk about, we've got this 30-something-year-old mid-level provider presenting to your primary care office with abdominal pain, high stress from her job. And the way that I build the case is very much how I experienced care from providers. They looked and saw I was seeing, in some cases, up to 90 patients a day in outpatient urgent care. It's not sustainable. It's easy to hang your hat.
The urgent care grind.
It's not good. Yeah. And so I lead these medical students down this path where this patient is having nightmares. She's having abdominal pain, reflux. She had not one, but 2 angry patients that threatened her and her staff with guns. And so the students automatically assume it's a psych case. And it is, but it's also my case. So I change the pronouns on the one slide and I look at them and I say, when I decided to seek care for my suicidal ideation, and then you just see everybody in the audience kind of like, what's happening?
Wow.
And then I say, hey, what's the underlying physical diagnosis? Then we address the mental health. It's hand in hand.
It is. Absolutely.
So that's been Utah, Connecticut. I'm going to go to New York next month, and I'm doing a couple of public libraries. But honestly, I'll go anywhere. I want these stories to be told. I want to continue this conversation, and I hope to be a little bit of an antidote to the medical gaslighting.
Yeah, it's been so inspiring hearing your story and you just being so vulnerable and open with us. It really is. I think it's meaningful for both of us as providers and working in this field, meaningful for us to have you as our first guest. It's setting the bar very high for other people.
Thank you. Go big.
But I just think it's so important to talk about. So I'm glad that you're spreading the word with your book, but also with this tour and talking with students. It's so important.
And I have to thank you both for inviting me on. So there's a couple of online forums for MALS. MALS PALS. MALS PALS is the biggest one.
Okay.
And the National MALS Foundation has been amazing. They were only created a few years back. So I whenever I go on tours or anything, I put a post up in those groups and I say, what do you guys want me to share? How do you want me to portray this? Because it's not just my story. There's hundreds, thousands of us, and they're all desperate for somebody to listen.
Wonderful. So definitely also send me those, and I will add all of that to our show notes so that our listeners can absolutely access that. And look for Kateland's book. If you are not in one of the in-person bookstores online, you can buy this on all the big names.
Yes. Barnes & Noble, Amazon, Walmart.
You got it. It's there.
Yeah.
Yeah. So just however you can get it, read it, listen to it. However, is there an audiobook yet? We're getting that in the works?
Not an audiobook yet. So it's a small publisher. So I've kind of gone back and forth with them a little. I've had patients ask for audiobook and large print and hardcover. And they're like, well, let's see how the initial paperback run goes first.
Yeah, I understand.
You'll get there.
I would very much love to do that. Absolutely.
All right. So everybody get out there. Yeah, we'll put everything in the show notes, all of the links, and we'll definitely share everything on socials. We'll share all of Kateland's socials as well. And get out there, follow her, the right assistant, catch the episode of Grey's Anatomy. And I think that's what we got. So thank you for listening to Medical Media Mixer.
The perfect cocktail. Cheers.
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 Thanks for tuning in to this episode of the Medical Media Mixer podcast. If you enjoyed the conversation, don't forget to subscribe, rate, and review us on your favorite podcast platform. Your support helps others find the show. Want to keep the conversation going? Follow us on social media. We're at Medical Media Mixer Podcast on Instagram, Facebook, TikTok, YouTube, and on Pinterest, the Medical Media Mixer board.
If you'd like to support the show and help us grow, check us out on Patreon. Patreon.com/Medical Media Mixer Podcast. And on Buy Me a Coffee, buymeacoffee.com/Medical Media Mixer Podcast. If you have a topic idea, feedback, or just want to say hi, send us an email at medicalmediamixer@gmail.com. You can also stream all of our episodes and find more info on our website, medicalmediamixer.podbean.com. We're available on all major podcast platforms, so no matter where you listen, we're there. Thanks again for listening, and until next time, keep mixing medicine and media.